Okay, great. Well, I got to start by saying I was up in my hotel room a couple hours ago going through my talk, and I'm so happy to see it was only about 9 minutes. So I think it's supposed to every other time I've spoken here, I can relax and slow it down a little bit. I've been coming here for many years, about 9 years, and it's so great to see this conference grow and get bigger and bigger and really better and better. Guy from Lipedema Foundation said it very well. There's a lot of amazing nuances that people are presenting. It's so great to see. And the research talk today was just fantastic. I remember in Cleveland last year where I spoke, the whole surgery part of it, which is this. It was really daunting to patients. I said this in terms of all these different approaches and techniques, and it must be just get so confusing for all of you guys. And yes, there's a lot of different approaches to things. Today I'm not going to talk about a lot of nuances. I'm not going to show any before and after photographs. I've done that many times. You can find that in other areas, my website, my book. I'm going to talk about a concept that is a very important concept, and I really want to drive this concept home. I'm a guy who likes to develop concepts and a way of approaching things that I can understand, digestible units of things, and for people to understand too. And one of my concepts I introduced years ago is this idea of what I call the safe plane. And it really is, it's a simple concept, but it's a very, very important concept. And I'm going to try to drive that point home. So how do I advance it here? Oh my God. The green, okay. So my name is Dr. David Amron. I spoke yesterday. I'm the founder and medical director of the Roxbury Institute in Beverly Hills, California, and now Salt Lake City, Utah. I developed the Advanced Lipedema Treatment Program at the Roxbury Institute years ago to cover the gamut of lipedema therapy with many different types of specialists, myself, lipedema surgeons, plastic and reconstructive surgeons, and a whole team. Green button, there we go. Okay, so I still have nothing to disclose. I don't know if I'll ever achieve a point in my life where I've got all these disclosures, but still nothing. So my experience, this is my peacock slide with the feathers out there. So I'm a board-certified dermatologic surgeon since 1995. I've focused exclusively on liposuction as the only surgery I do for 28 years, complicated revision cases. I have over 25 years experience in lipedema surgery. I was the pioneer of lipedema surgery in the United States at least. I've done between 5,000 and 6,000 lipedema surgeries currently, and I do 6 to 8 every week. My practice is dedicated to lipedema, and I've trained surgeons around the world and in the US. So the ALT method, I'm calling it now, which is my way of going about doing liposuction, it's based on a philosophy. It's based on a number of what I call principles that I function within, and it's based on the way I go about things technically. I'm not going to have a lot of ability time-wise to go into details. There's a book that's out there that goes into a lot more detail about this. But my principles are big with balance and proportion. I've talked about this numerous times. Liposuction, and I developed this idea 25 years ago, is really a balancing procedure. It's about targeting disproportion. And in a person without lipedema, you're targeting disproportion. And with lipedema, you're also targeting disproportion in specific patterns as it presents in the disease. I talk about this concept of what I call the cosmetic units of the body and understanding how that plays into things. And when I do a cosmetic unit, I do really every millimeter of it completely. And we'll talk about the circumferential approach because lipedema involves entire cosmetic units. When it's involved in the lower leg, the thigh, it wraps all the way around, not sparing anything. So you've got to understand how lipedema presents and the respect of what I call cosmetic units. Safe plane we're going to talk about today. And then technique-wise, to run through it quickly, as most of you probably know, I prefer the avoidance of general anesthesia for a number of reasons, from safety to recovery to primarily results, at least the way I go about doing it. I rarely use general, about once or twice a year. I either do it under twilight or monitored anesthesia care or conscious sedation, or I can certainly do it under local with mild sedation. I do almost always do a circumferential, truly a 360-degree approach, every millimeter of it at one time, respecting the cosmetic unit. Again, lipedema is a circumferential disease. I think it's a better way of treating it completely, but it's definitely better from a cosmetic standpoint. And then my stepwise approach to try to get you to understand it, it's a few-step process, 4 or 5 steps. Step one is putting all the fluid in. A lot of terms have been mentioned. I do what's called complete tumescent liposuction using the fluid. Water-assisted liposuction, and Carol Kotowski said this very well. I mean, nobody does dry liposuction. We all use water. It's either the wet technique under generally general or versions of things, or wall the device, or putting all the fluid and preparing the tissue. To me, that's a very important step preparatory-wise. You get much more pure fat removal, the hydrostatic pressure of the fluid or clamping down on the vessels with things. So I tumesce completely, step one. Step two, I call this round one with liposculpture. It's a common device that we all use, power-assisted liposuction. Mechanically, it does a very good job of releasing fibrous tissue also. So I'll remove most of that, 80 to 85% in that step, and mechanically begin to release fibrous tissue. I then will go back with Vaser, which I don't like just doing unnecessary steps. I brought it in several years ago, and I do think it is helpful to further release fibrosis, especially subdermal fibrosis, that granular fibrosis. I then will go back and do my fine sculpting in step 4, and then finally I may do a final skin tightening step using a couple different devices. Jay Granzo commented on it last year, J-plasma removing, which I still like and find it's in my hands is very safe, completely safe, to help get some skin tightening with moderate loss of elasticity. If it's too far gone, they need to have lifting procedures. Okay, let's move on because I'm going to get a bit behind schedule. This is my book. I mentioned it yesterday. It kind of goes into a lot of detail about my different approaches and stuff like that. And it's a really good, hopefully, guide for the patient and pearls for the surgeon. Basic anatomy here. Surgeons like to look at anatomy. This is very basic. You're working primarily in liposuction in the subcutaneous plane, and on the top of that plane is the skin. It's in different levels: stratum corneum, epidermis, dermis. Then you get to the subcutaneous layer. You're working with liposuction, and then you get to a connective tissue sheet underneath that. Generally, the muscles below that, and in that plane, you've got fat cells. You've got smaller blood vessels, you've got lymphatic capillaries for the most part, and you've got a lot of fibrosis, connective tissue, and lipedema that is increased. And that is the safe plane that the surgeon really needs to be staying within with liposuction. They have no business really going out of that safe plane. You're just getting into unnecessary things and causing problems and this and that. So liposuction surgery, it really is very different from all other surgeries. Most surgeries are variations of cutting or sewing procedures and repositioning procedures. Lipo is different. It is a sculpting procedure in that layer of fat in that safe plane, and it's really important how it's done. It is really a graceful sculpting procedure under this blanket, and liposculpture is probably the right term. It's not just vacuuming things out and suctioning. You are moving through it and sort of sculpting that area. So let's put this well. We are all using long metal wands as cannulas under that layer. And it's the only surgery that I really think is so important to get really precise precision positioning throughout the entire surgery to stay in that safe plane. What happens if you disrespect the safe plane, the top part of the safe plane? Well, you'll just generally tend to increase your chance of skin irregularities, dents, ripples, cannula gouges, worsening cellulite if it's not approached properly, potential burns of using thermal-based devices, potentially even ulcerations. And, it can happen. It's crazy, but the surgeon's not skilled to actually just poke right through the skin with things. But more importantly, what happens if you disrespect it down below? This is where some of the bad stuff can happen with it. You can traumatize or damage muscles, nerves. If you're going to certainly get around areas like tendons, you start doing Achilles tendon, the lower part of the calf, and you want to really define that well, you've got to stay in that safe plane. Otherwise, you're going to get into things you shouldn't get into. You're going to increase the chance of bleeding if you get outside the safe plane. That's not potential. You're going to have potential compartment syndrome of bleeding if you get in that safe plane. You get bleeding, and that's different from what Karen Herbst talked about today with that type of compartment syndrome. You can increase your chance of seromas and hematomas. I'll just say this. I've never had one hematoma in over 12,000 liposuctions, and I've maybe arguably had one seroma. Now, why is that? A number of different factors, preparation tissue, but a lot of it actually staying in the safe plane. I think if you violate the deeper aspect of that, you're going to increase your chance of seromas with things. And then we get into the really concerning things. Organs, liver, kidney, lungs, spleen, aorta, vena cava, they've all been bagged and all can cause significant problems and even mortality with liposuction. And lastly, lymphatic damage. I've challenged this term years ago. What does that really mean, lymphatic damage? When I was damaged the lymphatics. But really, the more important thing is getting underneath that safe plane and getting to the deeper lymphatic branches and trunks. And if those are bagged, you're going to really increase chance of lymphatic damage. You've got to be so aggressive in that subcutaneous plane to damage the capillaries to really cause lymphatic damage. I put this up, I think, a year or two ago. I'm a little concerned because Carol Gutowski's after me, and he's going to tear this apart. Right, Carol? So this, this is an article I just referred to. It's a 22-year-old article. He's right about it. 500,000 patients. It looked at the risks of liposuction surgery under general anesthesia, and at least in this study, showed a 1 in 5,000 mortality for varying different reasons of things. The number one cause of death was DVTs causing PEs in that study. The number two was perforation of something you shouldn't perforate, like an organ in it. How to stay in the safe plane? Well, proper patient positioning is at least, I find, crucial with it, and avoidance of general anesthesia to be able to get your patient positioned perfectly. I find it's a big technical advantage. Proper preparation with complete tumescent anesthesia. I put the wall there, but really it's complete tumescent anesthesia. You want to create a bloodless field in essence and expand that layer as much as possible with the fluid. Properly designed marking strategic incision points, how you're approaching it strategically. These are long metal instruments that don't want to bend. And positioning is very important, along with incision points. You're off by an inch in your incision point, half an inch, you'll never go around to curved areas, especially as that plane gets less and less. The skill of surgeon in always staying in the safe plane as it gets thinner. This is a big one. I mean, we learn these procedures, and you learn a new procedure. It really takes a lot of skill in one procedure to get to be a mastery type of level with things. My younger associate, Dr. Vizernia, who's great, I spent about a year with him every day in the operating room, going through everything in terms of my technique. But a lot of it was actually the skill of perfectly staying in a safe plane with liposuction. And then the importance of counter-attraction by surgical tech. I mean, this is a huge area that nobody ever really talks about. I mean, surgical techs, I don't use them just to pass me instruments. They're there as my dance partner throughout the entire surgery, and how they're counter-attracting the tissue is hugely important with things. When a tech starts working with me, they go through usually about a 2-month process with my previous techs and are trained in how I go about doing it. I don't like using per diem people. What happens if you stay in the safe plane? Well, you tend to get a lot less bleeding. I never use drains. I never have, and I don't find them ever necessary, at least in my practice with things. You get a decreased rate of seromas and hematomas, unnecessary damage to things you shouldn't damage, faster, less painful recovery generally because you're traumatizing things a lot less. And you tend to also get along with the functional improvement. You tend to get a better cosmetic result if you're really great at staying in that safe plane with things like that. It's a really refined way of approaching liposuction. Thank you so much. This is my brood. We were in Thanksgiving last year in Lake Tahoe. So thank you so much.